都夠人開會啦嚇，咁我哋
We have formed a quorum. Let's start our meeting. Please invite the officials to join us.
交通嗰邊有
哦，
2012年前係啊，
佢呢個就冇提。
冇提咯，我哋就。
好，早晨。
Good morning. Good morning, government representatives. We are on agenda item 1, the issue of prohibiting chronic patients from carrying portable oxygen cylinders to travel on public transport. I would like to welcome the Undersecretary for Transport and Housing and your colleagues from the Bureau, the Transport Department, the Fire Services Department, and Hospital Authority. I thank members for raising this issue, and we have received a paper from the government. Simply put, the government recognizes that the patients who need to carry oxygen cylinders to use public transport should be allowed to do so. But now the relevant laws on public transport prohibit this, and as a result, these patients suffer some inconvenience. We have received some suggestions from occupational therapies and 3 professional organizations. And they are from the relevant professionals bodies in Hong Kong Occupational Therapy associations and other medical professionals, including the Hong Kong Thoracic Society and Hong Kong Lung Foundation. So over to you, Dr. So, for an introduction. For those who are suffering from different conditions such as chronic obstruction pulmonary disease, these patients require oxygen therapy. But because of the relevant laws, such as a dangerous goods ordinance, then such patients are not allowed to carry the compressed oxygen cylinders when they use a public bus. As we have indicated in the previous study, in order to promote the objective transport for all, the government proposes to amend the legislation to allow the access by such patients carrying oxygen cylinders for medical use. We have been liaising with the relevant bus operators and the departments, including the setting of the limit on the number of oxygen cylinders allowed on the bus, on the limit, and also the relevant rights and obligations of different parties, including passengers. We would like to make sure that this proposal can be implemented while ensuring safety of passengers. We expect to table a piece of subsidiary legislation in this council later this year under the legislative vetting procedure. And then we will talk to bus operators on and we will provide practical guidance on how this can be implemented. As for other public transport such as ferry, taxi, and so on, I have to point out that there are no similar restrictions on the carrying of oxygen cylinders for self-use. If an MTR passenger needs to do this, he should contact the MTR staff concerned. we would maintain communication and provide suitable guidance to facilitate the use of public transport by patients required to carry oxygen cylinders. Yes, as I've said, the expert advice is that the law should be amended ASAP. Thank you for bringing this item up for discussion. It's an old issue. The laws are dated. Well, in the past, bus passengers were allowed to smoke, and therefore there was the safety concern of having oxygen cylinders at the same time. It's not going to be difficult to amend the laws, but we don't have anyone from the SWD. There are thousands of COPD, chronic obstructive pulmonary disease. They can move around, but they need to use a cylinder, oxygen cylinders or oxygen generator. But the law doesn't cover minibus, public light bus, and ferries. So you should cover these in the amended law. Don't just cover bus and MTR. You want these patients to have mobility, freedom of mobility. And I would say that legislative amendments are not sufficient. Or you can provide technical support saying that it is safe. And the hospital authority is also saying that we have a dedicated team of people working on this. But what about support? I hope the Undersecretary can refer the matter to Dr. Law Chi Kong and his deputy. And public education is important. Very often when people see someone carrying a cylinder, they are alarmed that there may be an explosion, and some may even ask the driver to ban that passenger. So please tell the relevant bureaus that after the laws are amended, you have to embark on a public education initiative. Please tell people that these people just need to use these cylinders and it's safe. There's no safety implication for other people. The government needs to do this, but I don't know which department is responsible for this. So you may be concerned about other gas cylinders, but you shouldn't be in the case of oxygen cylinders for these patients. Well, these patients are also discriminated by other people. This is the work of the EOC. I have to declare my interest as a member of the EOC. This joint subcommittee on long-term care policy wants to discuss this, not because we want a technical amendment that the law should be amended and is allowed under the law, but we're talking about thousands of patients who need to get this support. If this is viewed in the context of community rehabilitation, then it's not just a technical issue of a legislative amendment. Although we don't have anyone from Dr. Law Chi Kong's bureau, so maybe I have been a bit long-winded. You should do more in public education. You should educate the relevant parties. And also, it's there is a need of full-scale medical support. I don't think that this is just about amending the relevant legislation in 2017-18. Well, the Occupational Therapists Association conducted a survey saying that in June about 6,300 oxygen cylinders are in use. Dr. Su. Thank you, Dr. Joseph So, for your question. For non-franchise bars, taxi, ferries, and relevant are not prohibited by the respective laws. So passengers of these modes of public transport can carry the oxygen cylinders. As for public education, full support, and consultation, we will refer the matter to the relevant bureaus and departments for information and action. Mr. Kwong Chun-yi, Dr. Joseph Lee has put it very nicely. These patients are suffering from some breathing related problems, and they need to use an oxygen cylinder, but as a result, they are not allowed to board a bus or use the MTR. It's said that it's related to some historical considerations, such as back then, the bus passengers were allowed to smoke on board a bus. So I am a bit surprised that we have not paid sufficient attention to this. And we have received a submission that more than 100 people from the members of the Pneumoconiosis Mutual Aid Association have to use this. According to Public Bus Service Regulation 14A, no one should take on board dangerous goods, regulated dangerous goods, including oxygen cylinders.
After the review, of course, you shouldn't immediately make a full relaxation, but we must try to understand what is the risk in respect of the oxygen cylinders. Well, patients who do not carry the oxygen cylinders will not be able to go into the community. So I hope that the Bureau, of course I understand that we may need to go back to the relevant Bureau to tackle this issue. But I think this is rather sad, because in Hong Kong we have thousands of patients who suffer from this condition, and they are denied access to public transport. So it's a hidden barrier for them. I hope the Bureau will really try to work on this expediently. I think the problem has existed for many years already. I wonder whether we could be given a timetable as to when you can come back to the relevant panel and tell us what you are doing to follow up on this matter. Mr. Kwong. The Undersecretary already said that during the current legislative session, they will, by way of positive vetting, to negative vetting, to propose the amendments. At the transport panel on the 12th of April this year, we already discussed this question. In the paper from the administration, the government said that they were talking about back in 2012, the administration has already proposed amendments to Section 48 of the public bus regulations so that we can proceed with the negative vetting procedure. So this was what the government told us in 2012. We are now in late 2017. They are saying this again. Deputy Undersecretary, Mr. So? Thank you, Mr. Kwong, for the question. We'll certainly listen to all the stakeholders to ensure that while we allow people carrying oxygen cylinders will have the right to board public buses. We also have to secure the safety of the passengers. We'll continue to liaise with the stakeholders to ensure that we'll come up with an option that is acceptable to them all. As we said earlier on, we will, by way of negative vetting, submit the amendments to LegCo so that the amendment could be effected as soon as possible, and that the patients will be able to go about in the community as early as possible. Permanent Secretary, we understand that the amendment of the regulation has been slower than expected, but we're now expediting our pace, and we are sure that during this legislative year we will be able to complete the negative vetting procedure. I understand that Mr. Kwong also pointed out that legislation alone is not enough. We've also found out that for other forms of public transport, their respective regulations are not as restrictive, and they actually allow patients carrying oxygen cylinders to board such forms of transport. But why is it that people carrying oxygen cylinders are not able to access public transport? This is something that we are concerned about, and we are now working with the TD, the FSD, and the Hospital Authority and other relevant committees to communicate so that we can help the stakeholders better understand the regulations and ensure that the operators of other forms of public transport understand that the regulations do allow people to board, to carry oxygen cylinders onto the vehicles. So we will, through the transport operators and patient groups, to embark on further communication and public education, and we will be prepared to provide supplementary, information for members. Yeah, you will also be working on the guidelines. Yes, we said that earlier that we need to ensure that there won't be too many oxygen cylinders on a bus. So there will be guidelines to remind the transport operators, and this would also apply to the operators of other forms of public transport. Mr. Siu Ka-chun. Again, we're talking about oxygen cylinders. Under Secretary, I think you were an educator earlier. I think you would believe in the functions of education. Today we're talking about discrimination against the carriers of oxygen cylinders. I'm sure we can do something to help by way of education. There are many people who need guide dogs are encountering all kinds of difficulties, but it's not been so long. So long as the government is aware, the problem can be rectified. So, and the public will be more ready to accept it. For patients, I think the community is ready to accommodate and accept them. So I have a more detailed question. You quoted figure of 6,300 such patients. I'd like to know whether this number is confirmed by the government. And secondly, among the 6,300 patients, other than the people suffering from chronic pulmonary restriction diseases, what other are there other patients suffering from other diseases who also need to carry these oxygen cylinders? I want to get a clearer picture. I'd like to know whether 6,300 is the aggregate number. Could you give us a detailed breakdown? And for barrier-free public transport, I don't think we should just talk about it. And you said you will be preparing some guidelines. Will they apply to the KMB, City Bus, the Lantau Bus, and Long Wind Bus companies, as well as the PLB operators? We all know that if you go to Prince Margaret Hospital, the patients must take the PLB. Does it mean that the PLB operators will also be bound by these guidelines. Dr. So, we believe in the power of education, because education can really change or improve people's concepts or mindset. Regarding the numbers, the chairman mentioned the number 6,300, and this includes people suffering from chronic pulmonary diseases who would require long-term treatment. This is actually based on the findings of the occupational therapy occupation. You mentioned the PLB. The proposal to amend the regulation focuses mainly on the franchise buses. For other forms of public transport, people are allowed to, carrying oxygen cylinders are allowed to board such vehicles. But because of some misunderstanding, patients are not able to move about so freely. When we amend the regulation regarding franchise buses, we are going to plug the loophole so that for these patients who need to go out to the community, they have the right to board public transport when they carry the oxygen cylinders. Undersecretary, when you talk about education, and in the paper you also talk about guidelines, could you give us a timetable? The public education that you talk about, or education in respect of the stakeholders, what do you propose to do? Permanent Secretary? I think as far as education and guidelines are concerned, the biggest issue now is that since the regulations governing the franchise buses are rather old, and we need to amend the regulations. And during the current year, we will be proposing the amendment. So we can cover the franchise buses, but like Mr. Siu said, what about the franchise bus PLBs? Well, actually, at the moment, patients are carrying oxygen cylinders are allowed to board these PLB buses. We've heard this point 3 or 4 times, yes. We'll certainly work on the guidelines, because we can work faster in these areas because we've already talked to the service providers of public transport, including the ferries, the PLBs, and so on. We've already done one round of public education with the operators. As for the guidelines, they will be ready in 2018, and they will be then forwarded to the operators of public transport. I don't think he has answered my question, or he's given the wrong answer. My question is, other than those patients suffering from chronic pulmonary diseases, what other patients would need to use these oxygen cylinders? Do you have a breakdown? The Deputy Secretary also said that there should be we need an age distribution of these patients. I would also like to have a breakdown of the different types of patients who would need to carry these cylinders. Dr. So, other than chronic pulmonary restrictive diseases, which is the most common type of disease requiring the use of such cylinders, there are other chronic patients with the same need. For example, chronic patients suffering from pneumoconiosis and other suffering from chronic lung diseases. They would need they also would require long-term oxygen treatment. But we do not have the accurate numbers offhand. What about the number 6,300? Is that confirmed by the government? Deputy Secretary, we do not have a specific number ourselves. I don't think the hospital authority would have that either, but we will certainly base our consideration on that number. I think our discussion today is part of the public education. So if you don't have the number, and you say that you say that our discussion is based on this number, so I would take it that you also acknowledge this number. So after the meeting, could you give us the information, giving us a breakdown of the different types of patients requiring to use the oxygen cylinders? Please give us such information after the meeting. the numbers quoted by the Occupational Therapy Association is based on data supplied to them by the suppliers of oxygen cylinders. Leung Yu Chung. So since we will be doing this by way of negative vetting, and so far we don't know what would be the details of the amendment. So could you tell us your broad direction, first of all, and also could you give us details about the guidelines as early as possible? Otherwise, when you come up with the guidelines and they're not too satisfactory, it will be difficult to amend them further. So before, I wonder whether or not you'll be able to give us these guidelines ASAP. So that you can get feedbacks from the stakeholders, because once it is, formulated, it's difficult to change them. Secondly, Mr. Silkachin put it very well. Using the example of guide dogs, we all know that many of the blind people have suffered for a long time. Take the MTR, for example. Very often when they go to the MTR platform, they are stopped and harassed by the MTR staff, especially during the early years. According to your paper, in the premises of the MTRC, the patient would need to ask for assistance from MTR staff. I don't know how the MTR staff can help, and have they been trained to deal with these patients? Is it really necessary that they can only access the MTR station with the assistance of MTR staff? We've seen those wheelchair bound who must have be assisted by MTR staff to take the lift before they can go to the platform, and they have to wait for a long time to do that. And this is rather inconvenient for them. Would you streamline the procedure? Why, when they go to the MTR station, they can only access the station with the help of MTR staff? So in your guidelines and your amendments, I think before you do that, you should first, talk to the stakeholders. If you come up with the amendments very quickly, and then they may not be satisfactory.
And you also say that it's okay with mini public light bus and taxi. But the fact is that very often they don't allow these people to take the cylinders on board. You may want to do public education, but I don't see much publicity. For example, what publicity has been given to guide dogs? So you're just paying the lip service, which is not backed up by actual action. Because these tell us the entire plan if you are really committed. Deputy Secretary, Mr. Choi, with regard to the first comment, that is a framework of the amendment regulation. I can give you something in writing later. Simply put, it goes like this. We cannot say that the number of cylinders allowed will be unlimited. There must be a limit. And of course, it's not unlikely that all passengers will carry a cylinder. So we are going to impose a limit on each bus. We'll have to talk to the operators. And a passenger who carries an oxygen cylinder will need to inform the driver when he boards the bus. And then when the limit is exceeded, the next passenger will be asked to wait for the next bus. But this is not going to happen frequently. So the legislative work mainly concern the exclusion of oxygen cylinders for these patients under the coverage of dangerous goods on board. And then the passenger is required to inform the driver, and the driver needs to make sure that the limit is not exceeded. As for the administrative guidelines, the purpose is to facilitate the public bus operators to streamline the system of offering support, for example, MTR. And very often, passengers who needs to use an oxygen cylinder is also wheelchair bound. We will try to streamline the procedure for those who are not wheelchair users. And it's hoped that through the legislative amendment and the guidelines, we can do a better job in public education to prevent discrimination, and also to facilitate the use of public transport by these patients. Mr. Leung has asked whether the stakeholders should be involved in the formulation of guidelines. Yes. On the 10th, we already met some stakeholders on how the guidelines are to be devised. So, first of all, on the limit, sometimes there are two patients traveling together. And secondly, publicity about the guide dogs is a typical example of failure. Initial speaking will allow 2 cylinders to be on board a bus. We make reference to the present dangerous goods ordinance. We would make a final decision on the limit in due course. We hope we can do a better job in public education through the legislative amendment exercise, and we would work with stakeholders. Dr. Pierre Chan. Good morning. I support the proposal to amend the regulations. Let's not wait for another 5 years before we see the amendments tabled. Apart from pulmonary disease, you have hypertension, hyperpulmonary pressure disease. Some people are suffering from nerve atrophy related diseases that the patient cannot breathe. And there are also terminally ill, the cancer patient who need to use a cylinder oxygen. I support the facilitation of patients using public transport when carrying a cylinder, oxygen cylinder. But the precondition must be that no one is smoking nearby. Some 10 years ago, I was working in a hospital on a Sunday. It's 3 or 4 p.m. I was making my rounds in the wards. It was 3 or 4 p.m. and no visitor was there, so it was rather tranquil and calm. And I saw a patient with the bedding covering the head, and there's a tube connecting the cylinder, oxygen cylinder, to him. And then I saw some spark. I yelled for help right away. And then I grabbed the cylinder and took it away. If I didn't do that, there would be an explosion. And then FSD, police, all have people dispatched to the scene. The cylinder was safe. And even if there's a leak, it's all still safe, unless there's someone smoking nearby. Many members complained about the control over smoking, saying that you are depriving people of their freedom. So I support the legislative amendments. You don't ban smoking at bus stops, but only at the major transfer stations and terminus. The Undersecretary talks about dangerous goods ordinance when you want to cover public bus. What are you really referring to? What are the difficult issues that we need to pay attention to? Thank you. According to CAP 295B, dangerous goods general regulations, a license is not required for the storage of compressed oxygen not exceeding 2 cylinders. But under the public bus services regulations, no dangerous goods can allowed when a passenger boards a bus. So no dangerous goods are allowed on a bus at present. Undersecretary, are bus stops no smoking areas? If they comply with the law, that is. All right. I think let's wrap up the discussion here. We know that the government is going to introduce amendments to the public bus service regulation through negative rating, and in 2018 some guidelines will be formulated, and I understand that the guidelines will cover all the public modes of public transport, and you are going to involve the stakeholders as well. And for oxygen cylinders, you are allowed not more than 2. Actually, the government said this in 2012. And there were 4 more points covered. Members, please refer to the paper from the government dated the 12th of April 2012 and the relevant notes of meeting. Let me just add one more word here. There's a limit to the capacity of an oxygen cylinder. For some patients, 1 cylinder may not be sufficient when they go out, and they may need to carry 2 cylinders. So if there are 2 patients going out together, and if each uses 2 cylinders, they will have to board 2 different buses. So you should talk to the medical professionals and FSD and also cylinder users on the limit to be imposed, because the technical specifications and the performance of these devices may be different from that in 2012, and we should strictly enforce the no smoking regulation. So if the passenger informs the driver honestly, I believe safety will not be affected. So please provide the supplementary information in writing as soon as you can, and we'll now move on to the next item. Hospice services. This is in the form of a public hearing. Let's invite the deputations. We have 19 individuals and deputations attending this part of our meeting.
好，我哋歡迎咁多位團體同埋政府代表入嚟。
Well, now that the deputations and officials have joined us, I declare that we are now on the agenda item, hospice services. Through the arrangement of the Bureau and the Hospital Authority, we have visited a Caritas center on palliative treatment. And we have got a paper from the government covering the palliative care services offered by the HA.
And also what they do in the community, and also the care services for the terminal patients offered by the SWD. I will not further elaborate on I will not require the administration to further elaborate on that because it's all self-explanatory in the paper. So I would like to go into the discussion as soon as possible. So let me first of all invite the deputations to speak. Following that, I'll invite the administration to respond. For the deputation speaking today, you will not be protected by the LegCo's Powers and Privileges Ordinance. Of course, you can still freely speak your mind. Each of you will have 3 minutes. We hope that we have another 2 hours to go, and we hope that after members have asked questions, there will still be some time for further interaction or supplements by the deputations. I will first of all invite Mr. Choi from the DAB. Thank you. In Hong Kong, we now have an aging population. Other than the huge demand for medical services, hospice care service is seeing increasing demand. Let me first of all talk about the terminally ill and those who are immobile and patients who have relied on medical equipment to survive. Many of them are suffering from terminal diseases, and after medical treatment doesn't work anymore and the patient doesn't want to receive any further intrusive treatment, these patients will gradually, approach death. In their final days, they do not want to stay in the ICU or or palliative ward. They may choose to go back to home until they passed away, or so. How long that will take will depend on the age of the patient and the disease they suffer from. For patients choosing to go home for hospice care, the former will be focused on palliative treatment, and the treatment is provided during the medical facilities. When the patient receives hospice care, this is a new service launched only recently. But for people choosing to receive hospice care at home, there are certain legal restrictions. The law requires that if the patients don't pass away in the hospital, if they stay in the residential care and home center after they pass away, there would need to be a coroner's report. When there's suspicion, autopsy would be required. People dying at home, then the carers will need to ask a doctor to sign the death certificate 2 weeks in advance. Otherwise, again, the police would need to investigate to see whether there is any suspicion, and then draft a report to the coroner to decide whether or not there is a need for autopsy. If there are no suspicion, only then would the coroner's court sign the death certificate, and only then can the family proceed with the funeral arrangements. Given this complicated procedure, hospice care in Hong Kong has always been only provided by the medical organizations, so that we don't have to go through the coroner and autopsies. If the government wants to promote, hospice care at home, the government should also adjust its policies. Some elderly patients may suffer a lot of pain in the final phase of the disease, and they may need to be hospitalized. And the government may also need to expand, training for palliative care and hospice care. Other than providing medical treatment, you will also need to provide counseling, psychosocial support, so that they can die peacefully and in dignity. Thank you, Mr. Choi. Next, Mr. Lee from the New People Party. Thank you. According to the Census and Statistics Department, total number of deaths were 46,108 in 2016, roughly about 6.3. The topping the list were people suffering from cancer, circulatory diseases, and so on. Every year from January to April and December, we have highest mortality. The Economist and EIU published the Index on Quality of Death, and Hong Kong ranked we had a score of 66.6 among all the jurisdictions. Although we ranked number 22 worldwide, we ranked number 5 in Asia. But the report criticized the service provided in Hong Kong, which is on a lower level compared with high-income jurisdictions, especially the provision of quality of hospice care. The report estimated that 7% of deaths, patients who die, have received hospice care. The public hospice care is provided by the hospital authority. The purpose is to relieve the physical and psychological pain, and so that the patient can die in a dignified manner. The service is provided in hospitals and ambulatory centers. The HA has also set up different, centers to provide ambulatory palliative care. Public organizations under the HA. There are 40 such institutions. So far, only 16 hospitals offer palliative care treatment. Some public organizations which do not provide hospice care have tried to work with other organizations, such as the Tung Wah hospitals, to offer such services, so that the elderly can decide what sort of hospice care they receive. While we are concerned about the welfare of the terminal patients, we support the provision of hospice care for the terminally ill, and the hospice care is very important for these patients. It is indispensable for the expansion of public hospice care, our party will welcome that. We also urge the HA to review the service to see whether or not it's sufficient. And in hospitals which do not yet provide hospice care service, like Tung Hua, Fung Yau King, and so Tung Hua Group Hospitals, the government should provide hospice care. The coverage of hospice care in Hong Kong is very low, and our party is very concerned about this. So since there is a lack of public discussion, we urge the government to announce more detailed information so that we can, promote discussion on hospice care. We also hope that the Health and Food and Health Bureau will make reference to experience in the mainland and to work together with the stakeholders to promote a long-term strategy on hospice care. Thank you, Mr. Lee. Dr. Fong, thank you. Good morning. I'd just like to make 2 points. First of all, we need an integrative interdepartmental hospice care policy. And secondly, in implementing palliative hospice care service, I think we should focus more on psychosocial services. In the policy agenda, the CE also talk about the need to improve on hospice care, but it's only confined to the service provided by the HA. So even if we have, so the first thing is that if we want to want patients to actually pass away at home, we must include hospice care. So any palliative care provided outside the hospital, we need community support. So when we have schemes, many in the welfare care services, improving home care services must include the hospice care element within institutions. In different districts we have these institutions, but only new contract homes have the requirement to provide hospice care. For the old RCHEs under the subsidy scheme, will you also turn hospice care into part of the basic service to be offered by these RCHEs? If that's done, then in terms of manpower, facilities, resources, we will need to increase all that. The HA has indicated that they will, deploy more teams to the homes, and even the team comes once or twice for 1 or 2 hours in the homes, but for the rest of the time, the service is provided by the home itself. So how can we help the contract RCHEs to provide better hospice care? We will need to deploy more manpower resources. Thirdly, in the homes of the elderly, we should also promote life and death education. We need to step up the effort, not just catering for the elderly. We should also focus on support for the family and also support by volunteers, so that we can support each and every family to help their senior members to age at home. So will there be vouchers in future which has an element of hospice care? In every district, the centers for the elderly, how do they support each and every family so that they can better use of these informal services? Finally, for an integrated hospice care policy, I made 7 points in my paper. Since it involved different departments, I like to mention burial. No matter how good the community care is, many patients eventually will go back to the hospital to die because we don't have any mortuaries, except if you don't die in a hospital, then you need to go through the coroner's court. For the rank and file families, burial, funeral services, the hospital will provide them with the convenience. So integrated, hospice care includes 7 elements: life and education, collaboration, support by medical social support, enhancing the formal community care, and also regulate and enhance the funeral services, provide bereavement counseling, and finally professional training of different departments involved. Thank you very much. Thank you, Madam Fong. Next, Mr. Yu Lok Tin from St. James Settlement. Thank you. We are now operating a unit to help terminal patients to actually receive care at home. We provide one-stop service from hospice care until they pass away. It's been 2 years already. We have about 130 cases. I'd like to share with you the experience we have accumulated and areas of concern. For the elderly, they very much like to, age at home, and they want to stay at home as far as possible because that's the place that they're familiar with and the place that they like. Very often, when they need to go home, we don't have the supporting facilities, and therefore they have to stay in the hospital or they are forced to stay in homes for the elderly. One reason is that there are inadequate social services. So the choice of going home is not one that many would take. So medical-social collaboration would be the strategy going forward. So that for elderly services, I think this could be one element. And one of the difficulties facing the elderly is that their state of health may change all the time. 80% of the elderly client are elderly clients. Before they become sick, they have never received any community care. When their state of health suddenly deteriorates, they would urgently need the service. And even after they have discharged from hospital, they get many referrals, but they're not able to cope with so many people approaching them at the same time. One example is an old gentleman who was discharged, and he was given all kinds of information relating to organizations and they all approach him and his family. And the family may not even know the names of these organizations. So which organization he should approach for help, and the family may not know. So I think there should be an integrated social care team to coordinate coordinate. And as for the application procedure, I think we need to shorten the waiting time, and we should provide, urgently provide resources to help these people and to relieve the pressure on the carers at home.
服務轉介嘅過程裏面。
In handling inquiries and making referral services, we sometimes receive applications from those in the 40s, 50s, or 60s. They are not eligible for the elderly care services, but what can be done to help them? One more thing. Some people may be rather well off, but before they pass away, if they have relatives, that's better. But if not, then they need to use the enduring powers of attorney. But sometimes they find it difficult to entrust this to someone. So they would like to have someone from a government-recognized organizations to buy the service. For example, they can empower a statutory entity or the legal entity to provide the service in the context of hospice service. Mr. Yu Tak-bo, I'm from the Civic Party. In the 1980s, following the example of the UK, which was a pioneer in palliative care services. According to the EIU report, Economist Intelligence Unit, Taiwan ranks number 6. We have surpassed by Japan. Singapore is is 12, and Hong Kong is a 22nd, one of the underperforming economies in Hong Kong. So the end of life and hospice services are inadequate, and some elderly people have to suffer. In order to have seamless interface between the social service and healthcare services, the civic party would like to suggest that a comprehensive system be set up which is affordable, and we would like to make some suggestions. Whether one can pass away peacefully, the patient should be able to choose the environment he wants to be in, and also where he passes away. That depends on the establishment of a social network and relevant legislative frameworks. We have two recommendations. We hope the government would, in 3 years' time, follow the recommendation of the LRC in 2011 in respect of the enduring powers of attorney. The government should amend the law so that when the elderly is incapacitated, he may be able to make suitable suggestions on how to deal with his funeral and other matters. And there should be free legal advice service. And a consultant doctor post should be created in 5 years. And there should be a pilot scheme on a hospice and palliative care services involving the specialist doctors from pediatrics, oncology, and palliative care nurses to offer help to people who would like to plan for his palliative care, and also to provide professional advice to people who need the service. This will be much welcome by grassroots people. The government should be committed in offering palliative care and elderly services. There should be the formulation of a clear policy direction so that people can enjoy a peaceful twilight years. Well, with an aging population, we have many serious problems such as resource allocations, and the quality of death is not good in Hong Kong. We have more and more terminally ill patients, and there is a growing demand of hospice services. And this has also affected the long-term elderly services. In the long term, the government should pay attention to the service qualities of hospice care. More resources should be provided, but we should not just devote our resources to just one aspect. There are 7 clusters under HA. They have palliative care services for the terminally ill patients, and also the HA has improved the provision of resources and the service delivery modes and the use of interdisciplinary approach to relieve pain suffered by terminally ill patients, so that the quality of life of these patients can be improved. But the waiting time for beds under hospice care is not satisfactory. And the private homes have been exposed to have problems, and cases of neglect have been reported. The government should improve different measures so that those who are about to pass away would not be mistreated and would be able to pass away with dignity. Giving more resources will not solve the problem. You should look at the shortage of beds and manpower, and we should have laws to allow people to give instructions well in advance. The government should not shy away from these issues. Many people are not really don't know much about giving additional medical and healthcare instructions for one's own care. The HA only promote such service for giving advance instructions to terminally ill patients. But because there are so many taboos in life education, and Chinese people don't like to talk about death, there's a need to promote life education. Our ranking is low in terms of life education. Quality of death is low. People should be educated to think about how one's death should be handled, and also to talk to one's family members to choose the most dignified way of handling this when one approaches death. I'm from Onwing Social Service Center. We have been providing service to bereaved family members. We conducted a survey among these bereaved family members, and we have gained to understand their mental state, and also the need to have life education. Hospice care is to ensure the quality of life before the death. But the resources are devoted to the terminally ill who is about to die instead of the family members. We know that it's important to provide the services to the hospice care patients, but does it mean that we should ignore the family members? And are we going to set up a task force to handle emergencies when they emerge? These bereaved family members have a long way to go after the passing away of a family member. For example, in a case the father died, the children had to worry about how to handle their life. These are young children suffering from the death of a parent. They have a lot of negative emotions which will affect their growth in the long time. When children face such traumas and without any solution, there will be negative implications such as disputes and self-inflicted injury. Since the government cares about hospice care and life education, resources should be devoted to help those people, offer help to family members. We should have life education to raise awareness, and students should be allowed to discuss the different values surrounding death in the classrooms. And we should allow people with such experience to share with the students on how to handle the passing away of family members, so that they can learn something from these people. And there should be visits to the hospice care units so that students can face up to one's own views about death, and also to treasure what they have got. It's necessary for everyone to consider death at another stage, so that they can face up to the passing of family members. Mr. Leung Chang-yu, good morning. Apart from hospice care, Hong Kong should allow euthanasia there are terminally ill patients, and they cannot be cured. Some have to commit suicide because they are tired of living. Sweden and Oklahoma, the state of Oklahoma, allowed patients who are beyond medical cure to do something. If the patient is under 18, then the family's consent is required, so that an injection, a lethal injection, can be given to the patient, and the patient will not be forced to live in pain. And for those who are old, such as those who are suffering from cancer and leukemia, they have to go to a hospital very frequently. Although these are part of life, my uncle was diagnosed with leukemia this year. He visited the hospital 4 times in the year. Every time a lot of checks and blood transfusion had to be carried out. Well, he was compliant. He didn't complain about the medical procedure. The healthcare people treated him nicely, and he was well taken off by his family, and his grandson bathed him and fed him. It was very heartwarming, but the disease could not be cured. So all these came to very little.
Before my mother suffered from a stroke, after she suffered a stroke, she asked why we didn't allow her to die, because if she passed away, the family would have to suffer from so much pain. My father also had a stroke, and he lived for more than 10 years, and in 1996 he passed away. If the government could allow for euthanasia as an option for the patient, so that they can leave the world peacefully without having to suffer from all the pain, that I think would be better. Thank you, Mr. Leung, for that sharing. Next, Madam Lee Fung King. Thank you. I'm a retiree. I now basically look after my 95-year-old mother who is suffering from dementia. Unless it's in the early stage, otherwise patients would not be able to take care of themselves, and the situation would deteriorate gradually. With the aging population, and furthermore, the people in Hong Kong are one of the people who live live long lives. And there will be more and more patients suffering from dementia passing away. In Hong Kong, we no longer have a policy to provide comprehensive hospice care, and we don't know what will be the aspirations of the terminally ill. So life and death education is very important. In the ESPB report published in June, we found that there was less than 1 page on this topic. The government is saying that it agrees that hospice care should be further enhanced, and hospice care should be incorporated into part of the elderly care service. The STB's what they say in the report is actually telling me that my mother is a woman. What I'm more concerned about is the relevant departments, such as the HA, the Food and Health Bureau, etc., and etc. Many of the representatives are sitting here this morning. So what concrete plans do they have to coordinate the provision of hospice care? Aging at home is the preference of many old people. My mother also wanted to age at home, and she even wanted to pass away at home. So improving home care service should be incorporated into the hospice care program. Education and providing support to the carers of the terminal patients, whether it's the carers or the patients, they all want a dignified service for the terminal ill before and after they die. I urge the government to enact legislation so that we can minimize the pain suffered from the patients. I hope that the patient can pass away in an environment that they are familiar with. Today, people may not be, live, decently, but at least the government will allow us to die in a decent manner. Next, Mr. Mochi Wai. Thank you. We are a volunteer group. We are concerned about life and death education and also bereavement counseling. Today, I cannot talk too much about hospice care. It's not a subject that I'm familiar with, but I would like to nevertheless share with you some, some cases to show the difficulties we've encountered in providing hospice care. There is a case involving a handicapped person who is a middle-aged person suffering from terminal disease. He didn't know how to approach to find out what sort of services were available to help him. He was a terminal patient. He didn't know how to, for example, plan for his own death, how he could interact, spend time with a family member during his final days. So we tried our best to help them, to see what services are available to help him. So what I found out, first of all, I'd like to ask whether the government has any plan to offer services for these patients. I'm sure some people in the hospital are helping this person, but the services in the hospital, offered by the hospital, is only focused on the medical aspect, that is how to actually relieve his pain. But whether it's the medical social workers, they have difficulties to offer further help. So this is all about coordination at the central level. When we provide a service, we have come across terminally ill patients who need to rely on hospital services to help to deal with the relationship with family members. In many cases, they don't know. The wife and the children may be under a lot of pressure, and sometimes we have to act as the intermediary. And you have family center colleagues and the schools offering service. So could the government provide? Does the government have a central service policy so that other than the hospital, we can also provide service at the community level so that those providing community service can work together with a doctor to provide the service? This is something we should explore. We have actually served other clients who even could not, access services that could help them. We've seen, for example, children who suffer a lot of anxiety during the process. So how do we help them cope with the anxiety? I think, timely life and death education would be necessary. So how can we help these children? And finally, as a volunteer organization, we're facing many difficulties. Sometimes we would need to raise funds ourselves and come up with means to recruit volunteers and to help. So in these areas, could the government help us and come up with a plan? And this is something that we'd like to bring up today. Thank you, Mr. Lee. It's really commendable that you provide such volunteer services. Next, we have Mr. Lee Chi-Young, right? Association for Parents of the Severely Mentally Handicapped. So I think we should help people the terminally ill to face death. In advanced countries like the U.S. and Singapore, they've already enacted legislation already, and also in 2009 that the government also published some guidelines, and the HA has also some guidelines, but in its implementation they're still stuck at the education or publicity level, and they're ignoring the implementation details. For example, there's a question about the authenticity of the certificate for doctors. When a family member passes away, the family members will be very sad. And those who are passing away, I think we do not have enough community service, and hospice care is way behind other jurisdictions. So the parents will not be able to take care of the children. The hospice care, I think there's only passive support after. So we are missing the most appropriate time. And as a result, the family members will live with regret after the passing away of the family members. For the family members who visit the family member who's in hospital, they also suffer. So I think in every hospital we should offer hospice care so that the children can leave the world in the company of the family members. The parents are also worried about their funeral and burial services after they pass away. Without any relatives, then there will be public burial. And in January, the Long-Term Care Subcommittee already discussed these issues. In July, the then Chief Secretary indicated that he would explore how we can enhance the services. But 3 years have lapsed, but the government has not really done anything on this issue. The Parent Association would like the government to really address this issue and come up with an interdepartmental hospice care policy so that everyone can end their life in dignity. I suggest that we should set up an interdepartmental working group to focus on palliative care and hospice care policy, and to come up with a comprehensive policy so that those who pass away can live in dignity. And we need to enact legislation to do that. And thirdly, there should be, for example, and the family members should be entitled to the right for leave to take care of the dying family members. When the doctor asked my daughter whether she would have any indication or instruction regarding palliative care and instruction about funeral and burial and so on. As my daughter's physical health deteriorated, I was under more and more pressure. I felt very guilty, and I had a lot of regret. I felt so helpless. I was worried I'll never see my daughter in her final moments. I've been to the hospital and I didn't see my daughter because in my absence my daughter was discharged. On one occasion I received a call from the hospital at 3 a.m. in the morning. When I woke in the morning, I rushed to the hospital immediately in the morning. Fortunately, she was all right. After that incident, I had never been able to sleep well every time she was in hospital. I was under a lot of pressure. I've already signed the medical instructions, but I still don't get any hospice care for my daughter. So I'd like to know, why is it that the present policies have so many loopholes? Like my daughter, she need to have a stoma. She need to sustain by an oxygen machine. So I don't get a lot of home care services under the CSSA payment. For my daughter who's living in the home, when I take her home, the SFB had warned me that if I took her home, we might be accused of cheating the government on CSSA payment. So all the government policies only take into account family income and not expenses. So what kind of support is that? when the government formulated its policies and services, you should, take a comprehensive look at the needs of the person and do not, offer services in a compartmentalized manner. Thank you. I think you pointed out what is the crux of the matter. Different departments now are only, taking a fragmented approach. We have the HA and the SWD present here today. I would like to invite them to respond in a while. Next, Madam Wong Yun-Hwa. As the other deputations pointed out, the Economist's report indicated that the quality of death in Hong Kong has a lot of room for improvement. Hospice care would allow the dying to live in dignity. And the Council of Social Services is following recommendations. First of all, we should provide a framework for hospice care for the home for the elderly. Most deaths now take place in hospitals. According to the 2016 survey by the Jockey Club, more than 70% of those interviewed think that we should provide hospice care in the welfare agencies and home for the elderly. Many welfare agencies now have pilot projects. We recommend the government should make reference of the effectiveness of these projects and come up with a framework for hospice care and provide more resources, provide interdepartmental coordination to promote the development of hospice care for home for the elderly. The welfare sector are now gradually improving, enhancing hospice care. Before we can perfect the service, we suggest that the government could provide more resources for the assessment team to assist the homes of the elderly, to provide such hospice care for terminally ill patients when they pass away in the home. There should be an arrangement for certified professional to sign the death certificate, and that we should specifically provide training on palliative care for the staff of these homes. And we also should recommend that we should build up, teams to help the homes to promote life and death education, to help the inmates to give pre-death instructions and so on. In the schedule accommodation provided by the SWD, it is recommended that the new home should provide room for hospice care. And these should include basic medical and hospice care, including oxygen machine, electrocardiogram, and so on. We also suggest that we should allow the service users to participate in planning for the death. Many organizations are now promoting life and death education, bereavement counseling, pre-death, instruction, and so on. A study showed that more than 90% of those interviewed do not regard death as a taboo. And they also pointed out that in Hong Kong, this is the best time to deliberate on hospice care. We therefore suggest the government should provide more resources to the organization to promote life and death education, so that the patients concerned can arrange for their own death, and more importantly, default medical instructions should be recognized.
Next, Dr. Yuen Kwok Keung from Palliative Care Medical Association. I would like to make a number of suggestions. The government should have a comprehensive palliative care policy for Hong Kong. In the there's a 67.19 resolution passed by the WHA on palliative care. So we'd like to know whether the FHB has come up with a policy on palliative care for all age groups in Hong Kong. Second, there should be a survey on the quality of palliative care. WHO conducted a questionnaire survey on palliative care service in 2015 to assess member states' service capacity. We would like to know if the THB participate in this survey and what are the findings. Third, we would like to talk about policy formulation and public participation. According to the International Survey on Quality of Death Index survey, Hong Kong are found wanting in both policy formulation and public participation. What has the Food and Health Bureau done to follow up the matter? Thank you. Thank you, Dr. Yuen. And next we have Mr. Ng Kwai Lun. I'm a registered embalmer and also a life and death educator. I have on my Facebook account I have received 30 to 40,000 likes, like other speakers. It's difficult to find suitable information on life and death education or palliative care or hospice care and bereavement counseling. These people who visited my Facebook account are more educated because they know how to use this service. But is there a better way for other people to be involved? You may think that I'm a professional on this. My grandfather passed away more than 2 months ago. He retired. He went back to his hometown when he was 78. After he had retirement. After he retired, he was 94 when he wanted to return to Hong Kong because his illness prevented him from staying in his hometown. And then because he had been absent from Hong Kong for a long time, he found it difficult to apply for services that he needed. When his organs degenerated, he was living in a residential home. And the doctors advised him to have a heart device to implanted, and when his kidney had problems, he was advised to treat his kidney problems. And I'm someone who is knowledgeable. There should be a medical social worker to communicate with the family members. And I had to spend a lot of time to let let my family members understand what that was about. And when we signed the advanced medical instructions, they were very reluctant to accept this. And I had to offer the printout of the HA guidelines, because that a specialist doctor in medicine had never done this. I understand that this is a challenge to them in terms of manpower and time required. So government should not just legislate for this. There should be proper training. Training for healthcare workers. And when my grandfather passed away, I did not take my grandfather to a funeral parlor. But the mall outside the space outside the mall is only 16 by 9 feet, and we were only given 1 hour for the ritual. It's a Princess Margaret Hospital, and if people want to had a funeral ritual there without going to a funeral parlor, they should be allowed better facilities. And we hope the quality of death to be good for the deceased, and also the family members would have a better life. We hope that people will age slowly and would pass away in a quality way and with no regret. Let's hope so. Mr. Leung Kok-hong. I slept outside this council in the protest against the amendments to the rules of procedure, so I was late. Sorry for that. The government came up with 3 policies for the elderly. They were supposed to age in the community, in the home, and with proper care. Some 20 years has passed. The first chairman of the Commission on Elderly Commission was Tam Yu Chung, a DAB member. It said that the government would like to address all these 3 policies properly, but nothing came through. I filibustered a lot, but there was still no universal retirement protection. It said that the money would have to spend on other things. What about aging in one's home? It's no good. What about residential homes? No good. And when there's a shortage of places in the residential homes, they would claim that they would enhance community support. Now the Elderly Commission is chaired by Mr. Lam Jing Choi. He was appointed by the CE. He said he wanted elderly people to have equality death in dignity. So you know the hospice care is not real. Would the family members get proper support to care for a elderly person who is about to die? If you don't devote sufficient resources to help them, both the family members and the terminally ill person would suffer. Our CE was once the director of social welfare. This current CS for A was the Secretary for Labour and Welfare. Why did we filibuster? Why did we want to put up a fight against the government? It's because we waited. We had been waiting for 20 years. And now the rules of procedure are about to be amended and no one can stop the government. Ask Dr. Elizabeth Guo this question. After changing the rules of procedure, could they be able to achieve what they are saying today in 2 years? If that cannot be done, they should bear the full responsibility, 400% of the responsibility. The loyalists are appointed to all these important councils and commissions. What have they done for Hong Kong? Thank you, deputations, for offering your views on hospice care and whether people can die in dignity in Hong Kong. It's really sad after hearing all these people. The Hong Kong people just want to have a dignified death. But we don't have comprehensive policies in terms of service delivery. It's inadequate, and the policy is healthcare based or healthcare dominated. Collaboration with other sectors are lacking. We have more than 40,000 deaths. But for palliative care and hospice care, we only got 360 beds. Whether we're talking about elderly people or other people of different ages, they were usually at a loss as to what they should do, and the family members as well. What they receive are fragmented services, and some services are not adequate. 3 years ago, this subcommittee also discussed the same subject, and we brought up the same issues. And the government said improvements would be made, they would face up to these problems. Now 3 years have passed, and this subcommittee is also at its terminal stage. After this meeting, we will have to suspend our work, and we'll have to queue up again. So it's really an appropriate subject for this subcommittee. I hope the government, having heard the deputations, would respond to them in respect of the difficulties they face, their recommendations, and other issues. I hope the departments and bureaus respond to them fully. Let me give the floor to the officials now to provide their response. We have people from FHB and SWD, HA and HA as well as FSD. Let me ask Dr. Choi Tak Yi, Undersecretary, to speak first. Thank you. I thank the deputations for expressing your views today. It was called Xinzhong or hospice care in the past in Chinese, and then we'll have a service for the terminally ill. Apart from doing it as a sort of health care, we should also take care of the person himself, the family members, the welfare agencies and other service providers. We should work with them to provide a full network of support. In the policy address, it's been stated that we are going to revise relevant laws so that terminally ill can choose to remain in their homes before they pass away. Starting from last year, we commissioned a study to be conducted by the CUHK on terminal ill service quality, and through the different projects jointly launched with NGOs, would like to offer more support to the relevant service recipients and their family members.
We've heard some individual examples. Perhaps after the meeting we can communicate with the deputation as to how we can make some improvement in respect of some of those cases. And with that, I will now defer to my colleagues in the other departments to supplement. I heard the chairman of the Palliative Service Association pointing out that the WHO had conducted a survey on the quality of palliative care. Earlier on, we understand that there was a resolution of the WHO. Have we followed this, the recommendations? I believe this is also under your purview. Yes, I have read those papers regarding the standard. I believe we have not directly participated, but it's whether regarding the review on the adequacy of the services, I think the HA has a report on palliative care. We've also commissioned a jockey club to conduct a study. We are also working towards the direction to gradually improve the service. Regarding the Jockey Club study, when will the findings be released? End of next year, 2018, yes. So this is a study regarding hospice care for the elderly and also elderly service. So the study is about the overall service of the elderly, which includes, hospice care, medical services for the elderly who are terminally ill. Labour and Welfare Bureau, Ms. Jiang. Madam Pang, SWD. Some deputations pointed out that in the plan for service for the elderly, we have suggested that we will be stepping up hospice care service. In September this year, we already deployed a new schedule of accommodation. For the residential home for the elderly, we have already included such equipment. That is, there should be a hospice care room. For all the contract homes, there are 29 in total. 17 of them have already joined the provision of hospice care. For the remaining 12 homes and all the new contract homes going forward, we will be providing more resources for them, so that after 2019, all contract RCG will provide such service. For subsidized homes, we will once again talk to the profession, because our schedule of accommodation has been updated already. And we also have, for welfare, private land for welfare users, we have received applications for the redevelopment of homes for the elderly. We will talk to the professions to how we can provide for this element in the service of the homes. For staff training, manpower, and other resources, for contract homes, we have already reserved resources for them. For subrented homes, we will follow up on them later on. On staff training, this is very important because it's not just the hardwares. What is equally important is whether the staff can, perform their duties properly. At the middle of the year, at a Council of Social Service meeting, we've also talked to the trade. We found out that some of the frontline staff are not well prepared. Going forward, I believe we will need to further step up the training, and we need to liaise further with the profession in order to promote, full support, so that the staff would be ready. But we will need time to train them. Thank you. Ms. Pang. We have 700 odd homes for the elderly. 17 have joined the scheme. And these are contract RCGs. For the subrented homes, you said you will follow up. Do you have a timetable? We have more than 500 private homes for the elderly. Will you need to work on them as well? I think we need to do it step by step. So far, we don't have a concrete timetable. As I said, for the subrented homes, even the frontline staff, we need time to train them. For the private homes, as I said, hardwares are important to implement this among the private homes. For staff training, we will try our best to ensure that the staff will get the training. However, to come up with integrated package, I think there's still a long way to go in respect of the private home to see whether the whole package of services can also be implemented in the private homes. The readiness of the staff, because if our whole society, in our society we have so many elderly persons, and the prospect of death is something that frontline staff cannot evade or ignore. So everyone needs to be prepared. But even some of our social workers are not well trained or equipped. And I certainly take this back, because in terms of bereavement counseling, life and death education, we do offer training to the social workers. If they're still not yet ready, then we will make further improvements. I hope you will come up with a concrete plan for that. Next, Dr. Lau or Dr. Liu from the HA. Thank you. I'll just make a few responses. The HA understands that while we've been offering palliative care for decades, there's still a need to enhance that. And we also agree that we need to work together with the other professions. The hospital authority has 16 palliative care teams, but not all 16 hospitals have such services. Palliative care is a specialist service. We hope to offer the service on a cluster basis, and the 16 palliative care team comprising specialists would support the hospitals in all the clusters. We hope that going forward all the hospitals will offer the same service. We will have our palliative team and outreaching teams to offer the service. We see that we admit that there is a need to step up the service. In 2017, we already come up with a strategy for palliative care. You can access that on our website. And we emphasize several points here. First, we need to step up our overall governance. That is, among the different disciplines, we need to have better collaboration. And the palliative care team should work with the other medical teams, because the patients do not only need the care of the palliative specialists. Doctors from other disciplines, if they also have some basic skills about palliative care, then we can have joint treatment and joint care. So whether it's doctors, nurses, and paramedical staff, they should have the basic knowledge. And we also want to step up the ambulatory daycare services so that terminal patients can stay where they want to stay, be it the homes or the residential care for the home for the elderly. We also want to improve on supervision. Going forward, we want to make improvements. Secondly, regarding palliative care for children. In the past, palliative treatment for children was offered by pediatric teams, but we have found out that there's a need to enhance the service. In our strategy, we suggested that we need to develop a strategy for palliative care for children. We will set up a palliative care for children unit, and we need to have collaborative care to offer integrative care and treatment for the children. And thirdly, stepping up community care, working together with social workers and schools, so they can work together with the entire community to support the children in need and their families. Thank you. Dr. Liu and Dr. Lau, some deputations have pointed out that the HA doctors do not like to sign these advanced medical instructions, and they do not recognize such instructions signed by private GPs. Do you have a response to that, Dr. Lau? Dr. Lau? Advanced Directive, AD, in Hong Kong is not just limited to the HA. The Law Reform Commission has issued a recommendation. We now would enforce it by common law. When the patient is signed an AD, medical professionals will need to respect that. Right now, the HA has a guideline for our colleagues. Patients may have some ADs on hand, so how can we help our colleagues better understand about these ADs? There is a standard template about conditions under which the doctors will sign and so on. So we use the form to facilitate communication among colleagues within the HA. But that doesn't mean that the HA doesn't mean that we do not respect the other ADs. But for our colleagues' sake, if any patients or members of our public have ADs which have been signed by private practitioners, when they join the HA system, we would encourage them to sign the HA form so that when they receive different care, our own team, would know about the advance directive. Some deputations have also mentioned that to do this, we need to do a lot of training and education, and even within the government. Not many people will sign these ADs. In the hospital authority, we want to help patients to deal with this so that we don't have to wait until the patient is in a coma, at which time he will not be able to make the decision. And the family may not know whether or not we need to rescue the patient, and also whether resuscitation can help the patient, or whether we should, indefinitely continue with treatment, whether that will be invasive or traumatic. So, because treatment may cause harm to the patient, and the patient may suffer in the process. And this is something we don't want to see happening. I don't know whether I've answered your question. FSD, 3 years ago, at the meeting we had 3 years ago, you did not recognize the ADs, and you said you have a follow-up. You've given us a reply saying that according to the legal advice you have obtained, you say you cannot recognize the ADs. So you have the Fire Services Ordinance. You say that the AD dispensing with resuscitation is contrary to Section 70 of the Fire Service Ordinance. That is, fire services staff has a statutory duty to sustain the life of a patient, and there is a conflict there. Are you still maintaining that same position? Thank you. The FSD, where the law allows, we have an open mind towards the question of ADs. As the Chair pointed out, according to Section 70 of the FS Ordinance, the FSD staff has the duty to provide treatment and to resuscitate the patient. So to implement the AD will violate Section 7D of the Fire Service Regulation. That is, fire officers has a duty to sustain the life of the person concerned. So there is a conflict there. At the moment, therefore, we do not enforce the ADs. When we deliver the patient to the hospital and on the way, we need to provide proper treatment for the patients. That applies to all patients, including those who have ADs. I hope the Food and Health Bureau has heard that. So will the Labour and Welfare Bureau. On the one hand, the government encourages people to make advance directive, especially when the disease is irreversible. The patient wants to die in peace, and would not require any further emergency rescue like intubation and so on.
個嘅講法。
However, this claim of policy is not in line with the Fire Services Ordinance, and FSD is not going to implement a policy of following the AD. So unless we have the law amended, then the AD cannot be followed, especially when the family does not agree. So it's just one of the concerns of hospice care. we have another round for members. Mr. Siu Ka-chun, 5 minutes. We heard a curse that you would die a very painful death, or no, you have no peace. And you would. And why do we do this? Are all people in Hong Kong bad? And then when people pass away, you would post a RIP message on your Facebook account. If there's no policy change, no change in policy, the RIP will have to rest in peace.
咁一陣間都係圍繞住去問嘅。第一個問題當然係關於即係今日大家都成日提住嘅呢一個。
Well, we have been talking about this quality of death report 2015. I don't need to refer to the figures. We are number 22 in the rankings. It also mentioned that as a well-off society, the quality of death is so low, which is surprising, which is not normal. What is the Bureau going to interpret this ranking? We are 22nd, lower than Singapore, Taiwan, and South Korea. We are 22nd among more than 80 economies. Are you happy or are you not happy with this ranking? If there's another index in 2018, what do you expect that we would be doing? Are we going to be better than 22nd or worse than 22nd? I suspect that you won't answer such a question even if asked. Well, nowadays, legislators are easy to, because if asked for a figure, the answer is always no. I don't have the statistics. Well, what is the financial provisions for the palliative care or hospice care? And what's the proportion of total funding? How much is spent on training of doctors? What about the provision of palliative care beds? Well, we visited the Caritas Medical Care, the palliative care unit there. The capacity is 40 beds, but only 26 are in use because of lack of qualified and trained doctors and other healthcare workers. The same goes for psychiatric service and specialist service. So we either have a problem of a lack of land or money, or when you have the land or the manpower, you don't have the trained manpower. For FSD, has time been frozen since 2014? And this issue of advance directive, to whom is the directive addressed? Are you giving yourself the directive? I understand the FSD has a problem, but it seems that we are not moving forward in any way since 2014.
Do we need to involve the Chief Secretary for Administration to chair an interdepartmental working group before we can see some solution? And next, I want to talk about collaboration between social welfare and healthcare. When we do not need medical care, but psychosocial care for the terminally ill. Because we were talking about different conditions, constipation, pneumonia, and infection to the urinary tract. We don't need specialist doctors. Family doctors, given sufficient training, can deal with these problems, especially at the last 6 months of one's life. What they need is psychosocial medical care. Not that we don't have any statistics and data to support the suggestions, but it seems that we are not getting any concrete reaction. Dr. Elizabeth Kwok, I will ask the officials to respond to the members' questions in due course. I'm not familiar with this subject, hospice care. I thank the deputations for coming to share with us your work, your experience, and your views. And to the frontline volunteers providing hospice care for so many years, I'm grateful to them. I'm saddened by the issues exposed now. I would spend more time to understand the issues. So I would like to see if or how we can better collaborate to address the problems. And we are now repeating the same questions like those 4 years ago. And Mr. Leung Kok-hong a moment ago once again politicized the issues, and he named the political parties that in his view should be held responsible. This is regrettable. If the problem can be resolved by filibustering in this council, those problems would have gone now. So I think the important thing is not to politicize the issues. Yes, there are long-standing issues which have not been resolved for so many years. So this will require something bipartisan, and we should try to work with the government to find solutions. For instance, if all the political parties work together, we would be able to proceed with good progress and more quickly, as for example, in terms of rare diseases, patients suffering from rare diseases. But if you just criticize the pro-establishment camp for failing to do something for these people, I have been listening and here for the entire meeting. And if you criticize me, what do you really want to achieve? You want me to leave? I hope we will not be seeing the criticism and nothing else. Criticism itself does not create solutions. I hope, Chairman, you agree with me. I will try to look into the issues in detail. And we have talked about advance directives. The officials have not answered our questions. They have known this for years. They know that there's a problem with the fire services ordinance when someone has signed or prepared an advance directive. Are they going to amend the laws or adopt administrative measures to address these issues? Do we have a lead department willing to steer this, or are the departments all unwilling to take the lead? And if you don't take this up with the DOJ, the problems won't go away. They will still be there 3 years or 4 years down the road, I think we need some department to take the lead, to take up the leading role, to address the problems. And if the departments are unwilling, then members of this council may have to consider taking up the matter with the CS4A so that one department or some departments can be assigned this particular duty. So my question is, are any departments doing this at the moment, addressing the issues at the moment? Under Secretary. Let me say first talk about the implications of the quality of death report mentioned by Mr. Siu. Well, perhaps you should answer my questions first. Last year, we commissioned the Chinese University to conduct a study. One of the aspects that had to be looked into is the different laws on services. We are going to consider the recommendations in the report and then come up with different suggestions. So does it mean that this is going to be the responsibility of the Food and Health Bureau? For example, if the study points out that the Fire Services Ordinance has to be amended, and you know that the FSD is not under the auspices of the Food and Health Bureau, will the Food and Health Bureau then take the lead to amend the FSO? Or there are different laws for advanced directive. My bureau is responsible for the consultation in the past under the Law Reform Commission. The recommendation would be for a non-binding, non-legally binding advanced directive system, but advanced directives are valid under the common law. And I believe that this will be our responsibility. Well, I was talking about Fire Service Ordinance and other laws. Well, different laws are under the care of different bureaus. But in this context, it's about hospice care. Deputy Secretary, you are spending time on answers. Please provide direct answers. Well, it's not that we are going to amend the law without consulting the ordinance, without consulting the FSD, because FSD has to discharge their duties legally, which is the lead bureau, my bureau, FHB. So we have to wait until the study report is published. You have to wrap up quickly, Ms. Kwok. The report is about the improvement to hospice care. But why do you need to wait until the report is out before you know the FSO has to be amended? I've heard about this today. Without amending the FSO, you are not able to implement the advanced directive system, because it will be against the ordinance to follow the advanced directive. So why can't you do it now? But the study will cover laws. But it's not that we just sit and wait for the report is ready. But since there's a comprehensive report looking at the comprehensive issues involved, for example, if we allow people to pass away at home, we need to have a proper legal backing, and there are other laws involved. For example, how do we deal with the body after the disease has passed away? We would like to wait for the report, because the report will be looking at the comprehensive issues. But are we going to wait for a few years before we act on the report? No, we're ready. Well, we talked about the same issues 3 years ago. Nothing has been done. I don't really agree. For palliative care, We have this. I don't think there's any need to repeat what the Bureau has already told us. I was just suggesting that things can be done in parallel, as for example, legislative amendments which take time. So after the meeting, we should arrange further meetings with departments, and whatever needs to be done should not wait. Although this subcommittee would come to an end, but we would continue to follow up the issues. Mr. Leung Yu-chung, the day before yesterday, that we visited the palliative care unit at Caritas Medical Center. They offered very good service to patients and families. And if necessary, the family members can stay with the patient when at the very large stage. They have 26 beds, although the maximum is 40, but that's just a very small number compared with the number of deaths we have annually. And also the space for saying goodbye at the Princess Margaret Hospital is so small. So you just want to offer us something shorty, and little thought has been given to dignity. Many hospitals are going to be redeveloped or refurbished. Can something be done for so that you can provide a better room for families to bid farewell to the deceased? Can we see some improvement? Just this one. Let's not talk about other bigger issues. Dr. Miu from HA. Thank you, Mr. Leung, for your question. In terms of hardware, in new hospitals, the morgue and the farewell room will be improved, certainly, so that if they want to bid farewell in that room, or to carry out some religious rituals, that can be done. But for old hospitals, we have to wait until there is a refurbishment project. We certainly like to provide better facilities so that the family members can visit more often or stay with the terminally ill patient. We have some multifunctional rooms. You know, hospitals are crowded, but there are one-person, two-person rooms originally used for the, isolation care. If necessary, we can let these family members to use for the last couple of days. So given limited room, notwithstanding the limited room, we would like to offer such services. Well, for new hospitals, this is a piece of good news. But for old hospitals, well, the people cannot afford to wait. Can you somehow squeeze from the existing premises some bigger rooms for this purpose? Not just at PMH, but other hospitals. Well, I cannot really speak about this on behalf of the entire HA, but I can bring this message back, and many hospitals are trying to do more. Well, this is just a humble request for families with someone who is about to depart. I just want you to bring this message back. I have some time now for the attendees. Many of the questions have not been fully answered. Who would like to ask follow-up questions? Let me see your hands, please. Mr. Lee Ji-yong, 1 minute for each deputation. You have talked about involving stakeholders, but the public are not aware of this. Who are you talking about? The FHB is saying that they cannot see things comprehensively, and they need the study report. I know at least 4 cases like mine. So why are you saying that these are isolated cases? So what kind of service can be offered in the future? For my daughter, she needs oxygen, and there's a cylinder with her. The cylinder can only last for 2 hours. So how can you offer support to her? For the question of AD, for the non-hospitalization AD, you need us to sign every 6 months. But now the last AD has expired, and I have not been asked to sign a new one. And I know that that particular AD only applies to one particular hospital, but not others. All right. I hope the government and the HA would answer this question, whether the AD will be recognized by all or the different hospitals. Mr. Leung, Chang Yu. The Food and Health Bureau and the government have been evasive all the time. And I want to also talk about the Fire Services Department. Have you fully considered the wishes of the patient? Some would rather go for euthanasia. Mr. Tang Siew-pan mentioned this in 2012, and he wrote to the then CE, CH Tong, to ask for this. He was wheelchair bound, and he was so ill. He was immobilized. And there are other cancer patients. Oh yes, you mentioned euthanasia. We'll ask the government to respond directly. Many countries allow euthanasia. We've heard you. We know that. Thank you, Mr. Leung. Mr. Mo Chi Wai, I want to talk about collaboration between social workers and medical workers. HA also provides hospice care or palliative care, but it's still dominated by medical services. Are you going to plan for the longer term so the NGOs and social welfare organizations can play a part in helping the family members and or the patients in facing death? It's not very clear what we can offer, what we can offer as in our support service when the patient is about to pass away. I just don't see any involvement of collaboration between the social work and medical care. I mentioned the farewell room at a hospital, and I said that not many people can be accommodated, and one such room in the hospital for each hospital is not sufficient. We used to have 7 funerals. It was called Fuxao, operated by the FEHD funeral parlor. And now we have more funerals, and we have fewer funeral parlors. and their service quality varies. And the regulation of their services is backward. More and more people would like to have simple funeral rituals, and they would rather proceed to the columbarium directly from the hospital. And it takes half an hour to dress the deceased and to do some makeup, and then the family members will only have another 30 minutes to carry out the ritual at the hospital. Mr. Fong, we don't have a comprehensive policy for hospice care, and many of the services needed are not medical services. We also, it's not just about AD. We have to look at enduring power of an attorney. There's no way one can authorize family members to offer the services needed, and such efforts require interdepartmental collaboration. Why are we only having 7 licensed funeral parlors? Funeral services should be properly regulated, and that's a very good suggestion of providing leave to the bereaved. And district councils do not support more funeral parlors, and we need to have interdepartmental collaboration. And in terms of social service, they lag behind medical services for under the hospice policy. We need a comprehensive policies incorporating both medical and social services. The homes can only relieve us physically, but our mental and psychological needs are ignored. We want our family to be intact. We want to take care of our family members from the beginning to the very end. These are the wishes of parents of disabled children.
I think a comprehensive hospice care policy should be spearheaded by one department, but we're also talking about interdepartmental collaboration. I think we need such a policy. Today, the FHB is leading the administration, but do we have any response from the Secretary? I'd like to thank all the deputations for your questions and inputs. Although one can say that we don't have any literature called policy on hospice care, but in the last 30 years, both for hospital service, community care service, and so on, we are moving towards the building up of a better system to provide the service. Although we have not just referred to the report on the quality of death. Anything that can help us review and move forward, we are willing to. We always have an open mind, especially the Jockey Club Commission study, which we're looking forward to. But there are also many pilot projects underway, and these are seeds that can help us move forward. So from the legal angle, also in respect of the facilities, liaising with the profession and so on, about the cases we heard about, they always can, help us, give us room for improvement. We do not underestimate the importance of these cases, but in this chamber, it is not convenient for us to go into the details of individual cases. We need for these service providers to talk to the service recipients as to how we can do better. Regarding euthanasia, I believe this is a very complex social issue which we can make a decision today as to how we should move forward and how we should come up with a new direction. Although the law at the moment doesn't allow for euthanasia, but if we actively mobilize all the efforts to try to improve the comprehensive service for hospice care, I believe that's possible. Well, Dr. Choi, this is really disappointing. You say there's no literature, but then you say you have an open mind, and you say everything can become better, but you've not really said anything. You said you're waiting for the Chinese U report, but I don't see the government. I wonder on the question whether or not people can die in a more dignified manner. You don't have any position. You just say that you hope things could improve. That doesn't really help. There's a lack of coordination in all aspects. The quantity of medical services, that's not enough. There's problems regarding medical social collaboration, and the whole policy is led by the medical sector. There is no central coordination mechanism, so that the patient and the families are under a lot of stress. So the quality of death has already been ranked by international magazines as behind other jurisdictions. Faced with this very serious issue, there is a need to amend the law, and there's also and for the service delivery system and many of our facilities and even the whole burial service and supervision of service, we need improvements at all those fronts. So you need to tell the people of Hong Kong that is, when faced with this problem, how are we going to improve, and what is our views regarding hospice care, what's the direction going forward, and what we are going to do, and what measures we will implement, and how we will amend the law, or where we can provide additional resources so that we can improve the service and promote medical social collaboration. You should also give us a timetable. You should also say that we need to go ahead with life and death education. You need to work on all those fronts together, but where there is no collaboration. The deputations have highlighted all these issues. You say you don't have any literature, but you say you have an open mind and you're waiting for things to improve. If that's your attitude, then 3 years from now we will still be here talking about the same issue. There still won't be any improvements, because you do not have anything specific that you intend to do. You just say you have an open mind, you're waiting for improvements to take place, and you're just waiting for the CU report. I think the study we commissioned the Chinese university to do is a study to stringently look at where are the inadequacies and how we can come up with measures for improvement, or how we can set new policies. We certainly will follow the findings of the report, but that report is still being drafted. Once it is available, we will actively follow up on its findings. I'd like to know whether there is any other follow-up from the other departments. On medical social collaboration, some deputations ask who should be playing the leading role and how and where can they collaborate. FHB or the SWD from Ms. Peng? On medical social collaboration, I think both bureaus are equally important, would play an equally important role. I don't think any department should play a leading role. It would depend on what needs to be done. if the patient has medical needs, we need to pay more attention to his medical needs. I believe it would then the hospital would play a leading role, and the social workers can help. Regarding the taking care of the spiritual and emotional needs of patients, inevitably this would be under the purview of the SWD. So at different stages of the hospice care process, I think the form of collaboration may vary. Mr. Mo asked said that we're not just talking about medical social collaboration. He also talked about the need for medical social workers should take care of the needs of the family members. If there is a child in the family, the passing away of a family member may affect his studies. And we're talking about collaboration among different social workers. So each case, I think every social worker will have to consider. That is, if he needs to help a particular family, which are the areas where collaboration is necessary. And the social worker in charge will need to play the coordinating role. When we train our social workers, we always say that the welfare service we provide is actually from cradle to death. So life and death, and I think we need to be concerned about people's needs at different stages of life. I think if you go on, you will still be repeating the same points. You're talking about something which is obvious. The question now is whether or how, or whether you have a mechanism to facilitate medical social collaboration. The doctors have the part to play. If the welfare sector, the NGOs, and the SWDs, if you could, well, you have your own service, but there is no coordination between the two. If a patient is taken to the palliative care room, the family may need a lot of emotional support, and he may need to come up with some financial arrangement. Who's going to help them to follow up? The person who helps to follow up, does he have the ability to sort of liaise between the medical service provider and the welfare service provider to help the family, come up with a good, hospice arrangement? We don't have such a mechanism. And the deputations are saying that that mechanism is lacking. And there's no point for you to tell us, what the welfare department has to take care of. I don't think you are able to give us an answer. But I'm grateful for the deputations for pointing out that there is a gap here. I hope you'll go back and explore how we can bring, make that collaboration happen. In other countries, they have case management system. The case manager can actually straddle among different departments and professions to arrange for the service. They have a holistic plan. We don't have that in Hong Kong. And now I'd like to ask the HA to answer the question about the farewell room, quote and unquote. First of all, there is not enough such rooms, and allowing for just 1 hour for the family is not long enough. Is there any room for improvement there? Thank you. We thank the deputation for the suggestion. We'll go back and see whether there's room for improvement. For palliative care, I think we also agree that this is an area where we could make some improvements if it is feasible. What about regulation of the funeral parlor industry? That is under the purview of the FHB. Now, does the Bureau, so far we only have 7 licenses issued for the FHD, and the FHD, the service, funeral service that they offer now will need to be suspended for some time. So what contingency plan do you have? And also regarding supervision of the funeral parlor industry or the undertaker industry, any views? Regarding the regulation of the undertaker industry, and how we can, have better hospice care. We go back and think about this and see how we can improve. I believe there are many things that you need to think about. It's not the first time that we are raising these issues. For an advanced economy like Hong Kong, I think it is a basic demand on our part that people should have a more dignified death. I hope that you will not, like the Undersecretary said, just tell us you have an open mind. As the administration, you should have your own position. Since you have the power, or authority, you should make good use of your authority and the resources and the trust that we've given you so that people's life could be improved. Passing away in dignity is not something that anyone would refuse. So I hope you will really pay attention to that. Mr. Siu Ka-chun, your second round. It's almost time, so 1 minute. It's not my first round, my second round. I just want the administration to give us some figures. That is how many doctors they train every year, the utilization rate of the hospital beds and budget and so on. Please give us a written reply, right? And please do not. Does the HA have the figure numbers? Well, for the specific statistics, I may not have all of them. All I can say is, first of all, palliative care is not just provided by the palliative care unit, the geriatrics, the oncology, and other departments are also helping. We have 300 nurses, 40 doctors, and other therapists who are specialists in palliative care. But we have many people on the team, the medical team, oncology team. They're all part of the team. After we've launched the strategy, we want to gradually expand palliative care. First of all, we going forward for the next in 2018-2019, there will be several dozen more, nurses for palliative care. There will be more gerontologists. And in 2018-19, we will step up training for the other specialties so that other specialist doctors and nurses would know about palliative care. But I cannot, perhaps after the meeting I can see how I can give you more information, but it might be difficult to give you those numbers. Okay, please give us such information. 50,000 people pass away every year in Hong Kong. Most of them die in HA hospitals. But the global trend now is that people want to pass away in an environment that they are familiar with, be it their home or in a residential care home. We need to provide more support. The overall service and planning are not adequate. You may say that there are such services, but in reality, it's not sufficient. And some studies have found that we are very advanced 30 years ago. Now we are lagging behind. This select committee will now come to the end of its term, and I think we can only end our discussion here. I hope that we don't have to wait for another 3 years and come back and find that we are still standing still. We also talk about the question of patients' access to public transport when they carry oxygen cylinders, and they're facing all kinds of restrictions. We talked about this 5 years ago here. The government promised to do something about it. 5 years later, they come here, they say the same thing. Hopefully 3 years from now, this will not happen again. With that, we will have to adjourn here. And I'd like to thank all the deputations. And I'd like to thank our members for the support and our clerk who has given us so much support over the past year or so. We've conducted many visits, and we thank them for their support. While the work of this committee is put on hold, The Secretariat will help compile the report of all the work that we've done, and later on we will publish in this report all our previous deliberations and the recommendations that we have made. And we'll continue to urge the government to listen to your views. Thank you very much. We adjourn.